So today we're going to discuss bradycardia starting from basic science principles. The cardiac cycle comprises of phase 0, 1, 2, 3, and a total of 5 phases. This is because of electrical impulses based on time movements of ions across the various channels. Phase 0 is the rapid depolarization. It is driven by rapid voltage-dependent opening of the fast sodium channels. There's a swift influx of sodium into the cell. The membrane fully depolarizes, and as the membrane becomes more positive, then the sodium channels enter an inactivate state. In phase 1, it's primarily due to transient outward potassium current. The voltage-gated potassium channels responsible for this current are activated by depolarization, leading to a rapid outward flow of the potassium ions. In phase 2, there is a sustained plateau. This is a critical phase where inward flow of calcium ions through long-acting L-type calcium channels is balanced by the outflow of potassium to the various potassium channels, including the delayed rectifiers. The L-type calcium channels activate at a more positive membrane potential and inactivate slowly, therefore the plateau. Phase 3, L-type calcium channels inactivate and delayed rectifier potassium channels fully activate, leading to sustained outward potassium current. This outward flow brings the membrane potential back to a negative state. Phase 4 is the resting membrane potential maintained at a highly negative minus 90 millivolts by inwardly rectifying potassium channels, which favor the influx of potassium into the cell and prevent the significant outflow of potassium. In the ventricular myocyte, you have fast channels, transient outward channels, L-type calcium channels, delayed rectifier channels, and inward rectifier channels. And all of these are responsible for these various phases as we just discussed. And the ion species for phase 0 is sodium, phase 1 is potassium, phase 2 is calcium, phase 2 and 3 and 4 is potassium. In the pacemaker cell, you have hyperpolarization activated cyclic nucleotide gates, sodium and potassium, and they happen in phase 4. The T-type calcium, phase 4 and phase 0, L-type in phase 0, and the delayed rectifier current in the phase 3. Pacemaker potential is diastolic depolarization. Unlike non-pacemaker cells, which have a stable resting potential, the pacemaker cells never truly rest. At the end of each action potential, the membrane potential gradually and slowly depolarizes until it reaches a threshold, at which point it triggers the next action potential. The rate of depolarization is represented by the slope of the pacemaker potential curve, is the main determinant of the heart rate. Steeper curve means the threshold is reached sooner, resulting in a faster heart rate. Gradual depolarization is driven by the funny current, decline of outward potassium current, and a transient calcium current. The funny current flows through hyperpolarization activated cyclic nucleotide gated or HCN channels. It's activated by hyperpolarization. It's poorly selective, allows both sodium and potassium. It causes the membrane potential to slowly drift towards a more positive state. This um, reiterates that the gradual depolarization, as the membrane potential approaches minus 40, final push towards depolarization is provided by the transient T-type calcium channels. The sinus node's dominance as the heart's primary pacemaker is due to its faster intrinsic rate or a more steeper slope. The AV node is a small compact structure in the intraatrial septum that serves as a sole electrical connection between the atria and the ventricles. It's not simply a passive conduit, it's a critical gatekeeper, introduces a physiological delay of 0.09 seconds to the electrical impulse. It is essential for two primary reasons. It ensures that atria have sufficient time to eject the blood into the ventricles and protects the ventricles from excessively fast heart rates. The dual pathway system that causes decremental conduction. The slow pathway has a shorter refractory period than the fast pathway. Sinus rhythm impulse goes on the fast pathway. Under conditions of rapid atrial stimulation, the fast pathway becomes refractory. This forces the impulse down the slow pathway. A similar mechanism causes avinodal reentrant tachycardia. His Purkinje system compromises the bundle of his right and left bundle branches and specialized Purkinje fibers. Primary function is rapid and uniform conduction of electricity throughout the ventricular muscle. Rapid conduction ensures ventricles contract synchronously. Purkinje fibers have their own intrinsic automaticity, although the rate is 20 to 40 beats per minute. This makes his Purkinje system a potential source for ventricular arrhythmias. The neural control of the heart is by the parasympathetic and sympathetic systems. The vagal stimulation related to the neurotransmitter acetylcholine. Acetylcholine is important in controlling the heart rate. Muscarinic receptor activation directly opens a ligand-gated potassium channel, which is highly abundant in the atria, sinus node, and AV node. This outward flow of potassium ions through the channel hyperpolarize the membrane potential, which counters the depolarizing effect of the funny current and therefore slows down the heartbeat. Modulation of diastolic depolarization, the M2 receptor activation also decreases intracellular cyclic monophosicyclic AMP, and this reduction slows the activation of funny channels and decreases the opening of L-type calcium channels. Vagal stimulation, therefore, has a negative chronotropic effect, a negative dromotropic effect, that is reduced conduction velocity through the AV node. It has a minimal effect on myocardial contractility. Sympathetic control, on the other hand, involves release of epinephrine and norepinephrine from adrenal medulla. They act on the beta-1 adrenergic receptor in the myocardium. This increases the cyclic AMP, facilitates the opening of both the funny channel and the long-lasting L-type calcium channels. This increases the heart rate. The inward increased current of these channels steepens the slope of the pacemaker potential, therefore makes the heart go faster. Causes of bradycardia include aging, ischemia, medication side effects, and a lot of the causes that occur early in life have to do with hereditary and inherited forms of bradycardia are linked to genetic conditions known as channelopathies. There are several genetic syndromes, hypertrophic cardiomyopathy, which may come with 6 syndrome, the SCN5A, progressive cardiac conduction problems, the laminin AC it affects the nuclear potential in the laminopathies, and these are all the various genetic syndromes associated with conduction problems. Baroreflex is a centrally mediated reflex that regulates cardiovascular function. It's triggered by the baroreceptors, which are stress-sensitive nerve endings located in the walls of the carotid sinus. And when this is activated, it causes reflex inhibition of sympathetic pathways, activation of parasympathetic system. Net effect is reduction in heart rate and blood pressure. Barostim is a FDA-approved device for neuromodulation for treatment of heart failure that exploits this reflex. The SA node has two main groups of cells, a central core of pacemaking cells, an outer layer of transitional cells. Sinus node dysfunction can result from either a failure of the P cells to produce the impulse or failure of the T cells to transmit the impulse. SA node dysfunction originates from the sinus node. It can be sinus bradycardia, sinus pauses, chronotropic incompetence, that is a failure of the heart to increase heart rate in response to physical activity, tachybrady syndrome, where periods of slow heart rate are interrupted with periods of fast heartbeat. The etiology of SA node dysfunction is intrinsic in individuals over 50 years of age because SA node is replaced with fibrous scar-like material. It could be replaced in amyloidosis, sarcoidosis, and hemochromatosis. Extrinsic causes such as highly conditioned athletes, carotid sinus hypersensitivity, and drugs. There is a sinus exit block. The, there are two long RR or PP intervals without any PA wave during these intervals. Failure of one sinus impulse to exit the sinus node area to activate the atria. The pause is equal to the two sinus intervals. Just like second degree heart block, except this block happens in the sinus node. We also have a second degree SA block of a Wenckebach nature, whether it's type 1 or type 2. A heart block in the SA node is ascertained by measuring the PP intervals of the two preceding beats, comparing it to the beat with a long PP interval. So this one is Wenckebach, and this other one here is type 2. So in type 2, those intervals remain constant. Sinus arrest. In this, none of the sinus impulses are conducted. Here's an example. The patient had a sinus arrest here. It lasted 25 to 30 seconds. So it could be fatal. AV conduction blocks, the abnormal conduction through the AV node or the structures below it, such as the His-Purkinje system. It can be first, second, or third degree. First degree AV block is a prolonged PR interval. Its clinical significance is a pretty common finding in young, healthy individuals and athletes due to high vagal tone. It may not be so benign. It can also be a marker for underlying cardiac pathology such as degenerative fibrosis of the conduction system in older patients, myocardial ischemia, drug toxicity. A study from the Framingham cohort revealed that patients with prolonged PR intervals had an increased long-term risk of developing AFib and need of pacemaker and increased all-cause mortality. Second-degree heart block is independent failure of conduction from the atria to the ventricles. It can be Morbid's type 1 or Morbid's type 2. Morbid's type 1 is progressive lengthening of the PR interval with each successive beat until a P wave fails to conduct. In Morbid's, and then the QRS that is preceded by a P wave that occurs after that has a shorter PR interval. So PR interval is getting prolonged, and then there's a drought beat, and this is a shorter PR interval. Morbid's type 2 is intermittent non-conducted P waves without progressive prolongation of the PR interval. The RR interval surrounding the drought beats is an exact multiple of the preceding RR interval. Morbid's type 2 block, unlike Morbid's type 1, it's a more serious condition. Morbid's type 2 is almost always located below the AV node within the His-Purkinje system and is indicative of structural damage. It's far more likely to progress to complete heart block and cause significant hemodynamic compromise. Causes of Morbid's type 2, anterior MI, idiopathic fibrosis, cardiac surgery, especially such as mitral repair, inflammatory conditions such as rheumatic fever, myocarditis, autoimmune like lupus, infiltrative myocardial disease such as amyloidosis, hyperkalemia, and drugs. Third degree heart block is a condition where the atria and ventricle are dissociated, the P waves are not conducted. Sometimes the PP interval surrounding the QRS complex is shorter than the other PP intervals. This is called ventricular phasic sinus arrhythmia and could be mistaken for a second degree heart block. So in this example, this is ventricular phasic sinus arrhythmia. Thank you for watching. More to follow later.